or physical well-being? How's that, Mark?
Not bad.
Not bad? Okay.
Not bad.
And can I ask everybody to mute themselves except the speaker so we don't have background?
Themselves.
Okay, I hope everybody can hear me well enough. If not, I can turn up my sound a bit. Seems appropriate to have an hour on evidence and logic in a day when evidence and logic has not been the norm. So you don't need to see this, you don't need to see that. So ischemic heart disease has been one of the success stories in recent decades for medicine. Up until about the 1950s, it was actually the leading cause of death in the United States, particularly for males. Males would get heart disease and die of heart disease about 10 years younger than women. But if you were to follow the curve back here to about 1900, it would actually be pretty rare. And the reason it would be pretty rare is because people died of other things before they lived long enough to get heart disease. So they would die of infections and accidents and that sort of thing. But since about the early 1960s, there's been a long, slow decline in the prevalence rate of heart disease. And the reasons for that are multiple, but they start with the Surgeon General's report on smoking. Smoking has declined from about 60% among males to about 15% today. And the introduction of successful medications for controlling the risk. In the 60s, we had the beta blockers. In the 70s, we rediscovered actually that aspirin reduced the risk for heart attacks. In the 80s, we discovered statins. And in the 90s, we discovered ACE inhibitors. And when you add up those four medications, they are the most potent way of trying to prevent heart attacks, along with not smoking and exercising regularly, which reduces your risk about the same as the meds. And in addition to that, not doing cocaine. About 10% of heart attacks in the United States right now are associated with cocaine use. This is a depiction of what would be normal coronary vasculature. We're going to do a little bit of anatomy and a little bit of pathophysiology. I don't want to spend a lot of time on this, but I just want to give you some picture of what goes on in the heart. This is a relatively normal way in which the coronary vasculature presents. There's a segment that comes off the pulmonary artery called the left main, right up here. And the left main feeds two major arteries, the left anterior descending and the left circumflex. And usually in about 90% of people, there's a separate entrance or exit for the blood that feeds the right coronary artery. These are the arteries that feed blood to the heart and feed oxygen to the heart. And when we talk about ischemia, what we're talking about is inadequate blood flow to meet the needs of a given piece of tissue, in this case, the heart, relative to the demands placed on it. So if there's anything that interferes with this blood flow, you can develop ischemia. And there are sort of two things that cause that primarily. The first is atherosclerotic plaque, which can occur anywhere in your body, but is most common in the coronary arteries of the heart. And used to be thought of as just a normal part of aging. Used to be believed that up until about probably the 50s or 60s, that it was an inevitable part of aging to have the plaque build up in the arteries of your heart and eventually kill you as you got older. The plaque grows slowly, as far as we can tell, although that's not clear. There seem to be some people in whom it grows quickly for a period of time and then it becomes stable for a long period of time. It never regresses. It never gets smaller, it only gets larger. And as you age, it becomes calcified or rigid. So it interferes with the ability of the arteries to flex as blood flow demand increases or decreases. In severe cases, the blockages can get very, very high and they become impossible to detect in a living human being. But you'll see reports on people who have blockages of 99 or 100%. That's probably not true. They probably actually don't have a 100% blockage. They have a high grade lesion, but our ability to see the blood flow is so poor in a living human being that we can't really tell how much blood is flowing through. We'll talk about this in a minute. So coronary artery disease can happen in a variety of organs in your body, but the ones that are most commonly clinical problems are the heart, the brain, the kidneys, and the legs. So in the brain, the carotids can become obstructed and cause strokes. In the kidneys, occasionally you'll see people who get blockages in the renal artery that feeds the kidneys, and it can impair kidney function. And in the legs, you get the femoral artery developing atherosclerosis, which causes a condition called claudication. But the heart seems to be most prone. The reasons for that are probably multiple. One of them being the mechanical demands that are placed on the heart because it's constantly moving. And there may actually be sort of a stretch phenomenon that damages the walls of the arteries in some circumstances. Measurement of the atherosclerosis in living subjects, as I mentioned, is difficult. And it can be made difficult for a couple different reasons. The shape or location of the blockage can be sort of long and narrow and difficult to visualize using the technologies we have. Can be elongated. The most accurate way to know for sure is postmortem. And when people started comparing postmortem findings with pre-mortem suspicion of atherosclerosis, they were surprised to discover that there's a lot more atherosclerosis than we realized, in a lot more places than we realized. Non-invasive testing is possible technically, but very difficult to do and to get nice, pretty pictures of the blockages, and not very reliable. Surprisingly, one of the best predictors of a heart attack risk is coronary calcium. Coronary calcium tells us that the arteries are getting stiff, that the plaques are getting calcified, the arteries are getting stiff, and the risk of a heart attack is rising. It's not typically done clinically because it's not useful in terms of visualizing the anatomy of the arteries. And so even though it's possible to do it and people will offer to do it for you for relatively cheap fees, it's not really useful in terms of making decisions about how to take care of patients. In some individuals, atherosclerosis starts when you're an infant. And some infants will have what are called fatty streaks. And that's the beginning of atherosclerosis. And what's interesting about this is that even in infancy, there's a suggestion that infants who die in auto accidents and whose parents were at fault in the auto accident because they were drunk are more likely to have fatty streaks or to have more fatty streaks than infants who die in auto accidents where their parents were not at fault. So even in infancy, the stress of living with an alcoholic parent may begin to develop or to contribute to the development of atherosclerosis. Studies of young men killed in Vietnam and Korea found what was then a surprisingly high prevalence of atherosclerosis. About 30% of young men had some degree of atherosclerosis, and 3% had severe atherosclerosis, which would mean a 70 or 80% blockage in at least one artery. In middle age, probably most of us have some coronary disease, but some people do get to be 80 years old with no coronary disease. And those people, when people went back and tried to figure out who they were, began to realize that there are risk factors. There are things that predict who has these coronary blockages. People who have hypertension, people who have high cholesterol, people who smoke, and people who are sedentary are far more likely to have them. These blockages tend to occur at bifurcations in the vascular tree. Again, this may be due to mechanical strain and the effect on the walls of the artery. Plaques are not plaques. They can be fibrous or sort of like scar tissue, where they can be complex and unstable. There are some plaques where it appears that they rupture, the plaque tries to repair itself, it develops a pool of crap inside, which is a sort of a lipid-rich medium, and we think this happens again and again and again, eventually the rupturing of that plaque and the extrusion of the crap inside the plaque into the bloodstream is what provokes a clot. And the superimposition of that clot on where the plaque is the final pathway for most heart attacks, probably 85 to 90% of heart attacks. It is possible technically to visualize whether or not a plaque is, if it's large enough, whether or not a plaque is unstable. Intravascular ultrasound can do this. What I've never understood is why this isn't done more routinely. It may be the case that revascularization, angioplasty, where we place a stent that opens up the artery, is more useful with complex or unstable plaques, but not with a fibrous plaques. The degree to which the plaque invades the wall of the artery affects whether or not the patient is susceptible to spasm or vasoconstriction. That is, the systems that cause your arteries to relax are on the interior side of the wall, and the systems that cause your artery to spasm are on the outside part of the wall. So if the plaque is just large enough and not too large, people are susceptible to contraction of the artery, closing of some segment, and that in turn provokes a clot formation. As I mentioned, 85 to 90% of myocardial infarctions look like they're caused by superimposed thrombus on a ruptured plaque. However, there's some subset of MIs, heart attacks, that occur in people who have clean arteries, or people who have plaque in one artery, but the thrombus on postmortem is found in the clean arterial system, which is a bit of a mystery. Some people have the ability with slow-growing plaque or perhaps with the benefit of exercise, to grow collateral arteries around blockages. That is, you can grow your own bypass. And we're not sure whether everybody can do this, only some people can do this. We're not sure how best to do this, but one of the reasons for encouraging people to exercise is we think this happens over time if people have sufficient amounts of time to exercise to develop these collateral arteries. One of the mysteries of coronary artery severity is that it's not a correlate of anginal chest pain, which violates the belief system of most of cardiology. Most people would say, well, if you're having lots of ischemic events or transient ischemic events, you should be having lots of chest pain, but that actually turns out not to be true. This is what, in a living subject, is our best way of looking at the functioning of the arteries. This is a frame from an angiogram, which is sort of an X-ray where you're injected with a radio opaque dye, and we can visualize the arteries. So this is the left main up here. This is the left anterior descending. And you can see this segment in here where it looks like the blood is not flowing, or if it's flowing, it's a very, very small amount. This is the left circumflex over here. And then post-stent, if we place a stent in here, it looks like the blood flow is entirely restored or very close to entirely restored. Now, the mystery about stenting is that it seems to have no effect on heart attack rates. When this was first done, just as when bypass was first done, we assumed that this would have a big effect on heart attack rates. That turned out not to be the case. In the case of bypass surgery, it only affects heart attack rates if they're bypassing the left main region, and perhaps the three vessels, if you have three vessel disease. But in the case of stenting, when they're only stenting one or two vessels, there's no effect on heart attack rates. This is sort of a cross-section of what a bad visualization of cross-section of what a blocked artery would look like. This is probably about a 70 or 80% blockage compared to a clear blockage. Now, let's switch gears for a minute and talk about stress. When I use the word stress, what I mean is acute or chronic negative emotion. And specifically, I mean the biological response to acute or chronic negative emotion. Stressors are events that cause stress, and distress is the subjective experience you have when you're emotionally aroused. Most of us think of stress as something that happens to us. It's an external event that upsets us in some way and causes our biology to shift and in unhealthy ways. And that's the sole problem. And the fact is, it's a little more complicated than that. Stress can be acute or chronic. And one of the mysteries about chronic stress is that distress seems to fade. That is, if you live under stressful circumstances, over a period of weeks or months, people stop reporting feeling sad or anxious or on edge or angry or whatever, or having sleep problems, which is sort of a classic global expression of stress. This is a depiction of some of the damage of the Loma Prieta earthquake back in 1994, January of 1994. You may remember this. It happened during one of the NFL playoff games. And so it got a lot of attention. What's striking about this is somebody did a follow-up study of sudden death rates in the area, and it increased by about 150% on the day of the earthquake, which didn't occur on January 17th. In other years, it was only this year. There have been other studies that looked at earthquakes or looked at bombings or looked at other acute events like 9/11 and found an increase in this sudden death rate. So there's this sort of acute stress that it seems to be a trigger for cardiac death. This is another example. These are people who arrived at the Johns Hopkins emergency room with sudden onset heart failure. They refer to it here as cardiomyopathy, but that means heart failure. And these are people without known history of coronary artery disease. They had risk factors, but they didn't have known manifest heart disease. You can see that most of these people are women. Overwhelmingly, they're women. And you can see that most of them present with chest pain. Almost all of them present with chest pain. Although you have to understand that when we talk about chest pain among cardiologists, we're not just talking about pain. Sometimes it's crushing, a sense that something's sitting on your chest, or that your chest is going to explode, or there's a fullness in your chest. They use the term angina for sort of multiple manifestations of chest discomfort. But what's interesting about these events when they occur is that most of them are precipitated by the death of a significant other. But a number of fairly acute stressors can trigger, like being caught in an armed robbery, fear of choking, a court appearance, fear of a medical procedure, a fierce argument, or even having a bunch of friends jump out of you at a surprise birthday party. In a few cases has produced sudden onset heart failure. And what happens in these cases is the blood flow is obstructed. We're not quite sure, frankly, whether it isn't partial creation of a thrombus that then resolves, or is it all due to vasospasm or vasoconstriction. But most of these patients will show recovery over a period of weeks to months and a return to a relatively normal pumping function rather than retaining their level of heart failure and presentation. So they may show up with ejection fraction. Ejection fraction is the amount of blood that's pumped out of your left ventricle on average with each stroke of the heart to the rest of the body. And a normal ejection fraction is anything above 50. But these people will present with ejection fractions of like 20. So they have sudden onset heart failure. Now, some of our fellow citizens live in areas that are chronically stressful to live in. And of course, outside of this country, one sees people living chronically in war zones. In this country and elsewhere, people living chronically in poverty. These folks have higher heart attack rates. probably not just because of stress, but because of other correlated risk factors. And it's an interesting question whether we can help these people. There is some reason, I think, for being optimistic that we might be able to, that we'll talk about a little later. But the folks who have intermittent acute stress, either panic attacks or chronic anger, rage attacks, are people who have higher risk for heart attacks. So this guy, John Hunter, is an eminent physician. He holds an eminent position in the history of medicine. He was one of medicine's first great scientific surgeons. Up until Hunter and his generation came along, it was the barber surgeons who would remove abscesses and gangrenous limbs. And as near as we can tell, they had a mortality rate of about 90%. Hunter came along and took a sort of scientific attitude about surgery, and he became very interested in anatomy. He spent most of his life collecting weird anatomical specimens. And in fact, if you go to London, you can visit the Royal College of Surgeons Museum. It's referred to as the Hunterian Museum. And 3,000 of his specimens are still held there, and you can listen to the stories about them. Hunter was a Welsh, and he was a Celt, and he gravitated from Wales to London, which a lot of ambitious young men do, and trained with his brother. In those days, you didn't go to school to become a physician, you apprenticed. And he apprenticed with his brother, became a physician, was bored by it, and decided he'd rather be a surgeon. So he started the tradition in Britain, which is still the case, that you go and train with the surgeons, which meant the barber surgeons in those days, and you drop the use of the title doctor and begin to reuse the title Mr. Hunter was very ambitious, very hardworking, always overcommitted in terms of his time and energy. He was opinionated, he was stubborn, and most importantly of all, he was cranky. He was an irritable SOB, and there have been several people who've written about him. His biographer was his brother-in-law, who described him as, quote, very warm and impatient, readily provoked, when irritated, not easily soothed. He hated artifice, and he detested it in others. He spoke too openly and sometimes harshly of his contemporaries. And when he was in his 40s, he developed chest pain, intermittent chest pain. And he knew at that point, they had a pretty good understanding that it would herald sudden death somewhere down the road. He was able to titrate his physical activity to control the chest pain somewhat. But after a couple of years, his chest pain began to be provoked by antagonistic interactions with other human beings. And he had lots of those. And during this period of time, he said, quote, my life is in the hands of any rascal who chooses to annoy or tease me. He was such an eminent physician or eminent surgeon that the royal family selected him to be their surgeon, and they imposed him on the local hospital, even though the surgeons there did not want him on staff and found him obnoxious and difficult to deal with. On October 10th, 1773, he attended a meeting of the surgical staff where they were trying to decide whether or not to admit a couple of students from the University of Edinburgh. And one of the other surgeons got up and gave a speech about how Celts were barbarians and couldn't possibly be gentlemen and therefore should not be surgeons. And probably did this deliberately to provoke Hunter. Hunter flushed red. He stood up, he walked out of the room, and he killed over dead. And he had made arrangements to have his heart examined, and they found the thrombus, and the modern understanding, at least in the English language, of what a heart attack was began. So Hunter was what we would call a classic type A. He was overcommitted, hardworking, ambitious, opinionated, stubborn, controlling, but most importantly, he was cranky. And that crankiness is gone by several words in the literature. In the early days, the guys who sort of resurrected this idea referred to it as free-floating hostility. These days, we call it AlAI, aggravation, irritation, anger, and impatience. And it's sort of a cluster of emotions that you could describe as anger related. So the question is, did John Hunter's personality kill John Hunter? The question of how you prove something like this, what kind of evidence you want to be able to present, is ancient in medicine. And it goes back to Cook's postulates. Robert Cook was a physician back in the 1800s. He was curious about animalcules, which were bacteria, these things you could see under a microscope as whether or not they were causal of infectious illness. And he devised what are called Cox postulates: necessity, specificity, sufficiency. Necessity argues that if something is causal, it should be present in each instance of the illness. Specificity says that it should be absent in healthy persons or other illnesses. And sufficiency says if you take this bacteria and you inject it in a human being, you should be able to induce the illness. The question is, can you apply Cook's postulates to things like lifestyle risk factors, smoking or cholesterol or exercise? And the answer is not in a straightforward fashion. For example, if we take smoking, smoking is not necessary. Lots of people who develop heart disease aren't smokers. Furthermore, lots of people who are smokers develop other illnesses, not just heart disease. And we're not allowed ethically to do the kind of study that would tell us if we can induce it by forcing people to smoke. But nonetheless, the basic characteristics of this kind of evidence is correlational. That is, if you have a risk factor, does that increase the likelihood that you develop the illness? Or are you less likely to develop this illness rather than another illness if you don't have that risk factor? And sufficiency is essentially, can you induce the illness with the risk factor? Or the opposite of that, which is, can you reduce the likelihood of the illness or reduce the progression of the illness by taking away the risk factor? So some years back, I sort of tried to elaborate on Cook's postulates and argued that there was a hierarchy of evidence for this kind of thing, starting with natural observation or anecdotal evidence, correlational or cross-sectional epidemiological studies, prospective correlational studies, pre-post intervention trials, controlled intervention trials, and the gold standard, which is randomized controlled intervention trials. In randomized controlled intervention trials, you have a maximum ability to argue this group is as much like that group as I can make them, particularly if the sample's a good size. And if I only treat one and just observe the other, I can argue that the treatment made a difference in the outcome. So here's the prospective evidence that depression is a risk factor for ischemic heart disease. And this is a large number of studies that we summarized some years ago, looking at univariate risk ratios. So a risk ratio means how much increased likelihood is there that you're going to have a disease if you have the risk factor. So if you're depressed, you're about 2.6 times more likely to develop fatal heart disease, according to ANDA, compared to people who aren't depressed. And if you go down the list here, you'll see all of these risk ratios are above 1. If there were no relationship between the risk factor and the illness, these risk ratios would average about 1. If the risk factor was protective from heart disease, they would be less than 1. And you can see they're all well above 1 Um, and if you, to give you some sense of the importance of this, the risk ratio for developing heart disease as a result of having hypertension is 1.7. For cholesterol, it's 2.7. For smoking, it's 1.9, unless you're a 2-pack a day or more, and then it's 3.0. So these risk ratios are all in the same approximate magnitude or better as the standard risk factors. The problem with depression as a risk factor is when we get around to the sufficiency test and actually try to intervene for depression, we don't seem to be able to affect the outcome. That is, we don't seem to be able to reduce the likelihood of a heart attack. This looks like there might actually be a benefit for men, but it's you can see that the confidence intervals cross 1.0 here, so we can't say that that's for sure real. Furthermore, when we target depression and we treat both men and women, women actually seem to do worse with treatment. This doesn't cross the magic 0.05 threshold, but it looks like women are doing worse here. And there's actually 2 large trials like this where when we compare the male and the female samples, there seems to be this pattern of worse outcomes for women. There's another group of patients, and this overlaps with our female sample, which is treatment repressors. Repressors are people who don't like to talk about their emotions. They're uncomfortable. They get more stressed by trying to force them to talk about anxiety or conflict or depression or whatever. And if you try to force the issue with them as a psychotherapist, again, the patients seem to do worse rather than better. So the question is what we should be interested in, depression, or is it any chronic or recurrent negative emotion? And there's an interesting phenomenon that is inadequately discussed in my field as far as I'm concerned, which is that depression rarely occurs alone. People who are depressed often have symptoms of anxiety or chronic anger and vice versa. So there's symptomatic confounding. If we collect the scale scores from a large sample of the 3 major negative states and correlate them, they're correlated moderately to strongly, 0.25 to 0.75. 0.25 in the behavioral sciences, we consider a strong correlation. 0.75 is unheard of. It's very, very strong. Lifetime confounding. If you are diagnosed with an anxiety disorder, the likelihood of being diagnosed with depression at a later point in time or an earlier point in time is 80%. So the clinical presentation you make to your doctor will vary over time and will look like anxiety to him at one time and depression at another. Genetic confounding. If you have depression or anxiety and you have children, your children are as likely to have anxiety and depression. In other words, it won't follow your pattern necessarily. It may show up as a different phenomenon. And then there's neurohormonal confounding, where the meds that are used to treat depression are also the first line meds for treating anxiety. And actually, several of them also treat anger. The exception for this is benzodiazepines, which affect the GABA system in the brain and seem to be effective short-term for anxiety. They actually cause more problems than they solve long-term. But they don't seem to be that useful for depression or anger. And in fact, because of the nature of the drug, as it waxes and wanes in your system, it can actually make anger worse. So there's a lot of circumstantial evidence for arguing that these different negative emotional states are actually the same thing, just manifesting differently at different points in time. This is my measure of anger, depression, and anxiety. If you look at how anger correlates with depression, these are Pearson product moment correlation coefficients. Basically, these range from +1 to -1. And +1 means that for every unit that you rise in one, you will rise 1 unit in another. -1 means for every unit you rise at one, you will go down one for the other. And you can see none of these are negative, all of them are positive. And when you're talking about self-report, anger correlates very strongly with self-reported depression, self-reported anxiety. When you compare the patient, what the patient tells us about their emotional functioning with what the spouse friend tells us, which we obtain independently, it's still very strong. So anger correlates 0.36 with depression as rated by the spouse, 0.340. Depression correlates 0.367 with anxiety. And then these both correlate with type D. Type D is a European theory about we're not just interested in whether or not people are emotionally distressed, we're also interested in whether they're socially inhibited about dealing with their distress. And you can, it's also a prospective predictor of heart disease. So does anger, in fact, prospectively predict heart disease? The answer is yes. You can see the risk ratios here range from about 1.7 to about 5.0. And it predicts fatal heart disease as well as non-fatal MIs. This is the scale I developed for measuring AlAI. You can see these items. We asked them to rate them on a real-time frequency scale. Feeling and acting irritable, wanting to hit someone, feeling or acting hassled, et cetera, et cetera. And we score these according to normative performance by baseline sample. But what's interesting about this scale, what's important about this scale, is we ask the patient to fill this scale out, and then we have a directly parallel version that we have the spouse friend fill out. So we ask exactly the same question on exactly the same time scale of the spouse, and we do this to the best of our ability independently, and there are a couple ways we do it. If the spouse shows up with a patient, we take a copy out to the spouse in the waiting room and have them fill it out. If the spouse doesn't show up, then we say to the patient, it helps us to have the perspective of someone who knows you better than we do. Please give this questionnaire to your spouse and ask them to fill it out, and we would like them not to talk to you. And we give them written instructions until after they've filled it out. We give them written instructions for doing that and sending it back into us. So when we do this, we find a couple things. One is, this is a hostility measure from another questionnaire. We find that people who have chronic hostility are diagnosed about 6 years earlier with heart disease than people who don't. When we look at spouse friend ratings, they're also diagnosed about 6 years earlier. However, when we split our sample into males and females, the males get their disease 14 years earlier. The females, I don't have it on here, but it's about 2 years earlier. So this seems to be very much a sex-related phenomenon that men tend to underreport relative to their spouses, their emotional well-being. It's actually a student who told me to look at this, and she turned out to be right. This is the control group from the first intervention trial for type A behavior. And you can see that over the course of 4.5 years, the patients are saying, I'm not as angry as I was at the beginning. However, the spouse is saying something different. The spouse are the open circles here. She's saying, no, you're just as angry as you were at the beginning. And over the course of treatment, you show some improvement, substantial improvement. We looked at the severity of coronary artery disease and looked at a healthy control group. These are mall walking participants, and found that positive numbers here mean that the spouse is reporting more anger or depression or anxiety. Negative numbers mean that the patient is reporting more anger, depression, or anxiety. You can see that there's a dose-response relationship. The more severe your coronary disease, the more likely it is that your spouse is reporting more anger for you than you are reporting for yourself. And it's predominantly anger that this seems to manifest as. We see the same pattern with depression and anxiety, but it's far more prevalent for anger to be associated with coronary artery disease. Well, one of the points, the things I've had to live with and try to make peace with is my medical colleagues know nothing about any of this and are very bad at it. And this is a measure of depression, a standard measure, the Beck Depression Inventory, standard and widely used measure. Anything above 10 is considered a positive. And when we ask nursing staff or residents or attending physicians, is this patient depressed? They're very bad at detecting depression. If they were good at it, the scores would be clustered down here or clustered up here. These would be true negatives. These would be true positives. These are false negatives, and these are false positives. False negatives, false positives. So our ability to rely on our colleagues to detect this stuff is not good. This is a study out of the University of South Carolina done by Christine Skotsko. She was curious about New York Heart Association classification. This is basically a checklist that docs fill out about how bad your heart failure is. And she looked at ejection fraction, which is this pumping capacity of the left ventricle, and found that there was no difference between patients who were depressed and patients who were not depressed. And she looked at the respiratory quotient, which is the ability of the cardiovascular system to oxygenate, and there was no detectable difference. However, the doctor's rating of how bad your heart failure was strongly contaminated by depression and not recognized as such. We followed up a sample of 144 males with baseline coronary artery disease according to our cath lab, and asked the question 5 years later, who's dead? And it turned out that what predicted who was dead was hypertension, being a smoker at baseline, having diabetes, but the strongest predictor far and away was denial of anger. People who underreport anger relative to a spouse or significant others are far more likely to be dead 5 years later. This is the first intervention trial for type A behavior, and the control group received what was thought of as a placebo treatment, which was they would meet just as often as the treatment group, but they would talk about risk factors only, and they were not allowed to talk about stress. This is the treatment group down here, and you can see it at about 3 years. It becomes statistically significantly lower in terms of heart attack rates, and that's carried on out to about 4.5 years. Now, they looked at their control group, and they said after 4.5 years, they said it's not ethical for us to withhold treatment from the control group anymore because more people are dying in the control group than the treatment group. And they were dying at a rate of about 2 or 3% per year. So they started them on their counseling for type A behavior. And you can see that actually they had no deaths in the first year after starting counseling. They had a few non-fatal MIs, but they lived pretty well. Gunilla Beryl in Sweden took this study and replicated it with patients who had gone through bypass surgery and looked at deaths as a result of treatment and deaths as a result of being in the control group. And you can see there are many, many more deaths. There were no deaths in the treatment group for the first 2 years. And there were many, many more deaths over, she also followed them out about 4.5, 5 years. One of her students, Gullikson, also did a trial. These were people who were in the hospital for what's called an acute coronary syndrome, which means chest pain and some evidence that they're having ischemia, and also demonstrated a reduction in death rates. Is anxiety also a prospective risk? Well, the answer is the risk ratios would suggest that it probably is. However, there's only one treatment study. This was a sub-study of one of the depression studies that looked at a group of patients who scored with high anxiety at the outset. And in fact, they showed a significant drop starting only about 2 years in. This is sort of a mystery to me, why it takes 2 years for this to start to manifest itself. But there's evidence here that treating anxiety also reduces the risk. So in a way, it makes some biological sense because both acute anxiety and acute anger are associated with high levels of sympathetic arousal, these events that are associated with acute stress. So catecholamine production, sympathetic arousal, including vasoconstriction of the arteries, the propensity to clot increases during acute stress, platelet aggregability goes up. So it makes some sense that it would happen that way. We summarized all the treatment studies we could find for heart disease and stress a few years ago. And we divided them into the non-significant, the significant studies. And the non-significant studies, I think, are worth paying some attention to because there may be a signal here that we haven't established yet, but we should be paying attention to for future studies. One is this propensity for females to do worse. In both the Montreal Heart Attack Readjustment Trial and the Enriched Trial, there was this propensity for females to do worse. In addition to that, there are two moderate-sized studies that unfortunately were very short. The SAD Heart trial was only 6 months, CREATE was only 12 weeks. These were both SSRI trials. So they used these antidepressant drugs, which are really antidistressant drugs. Excuse me. Sertraline and citalopram. And you can see that it looks like they had a dramatic effect on the mortality and heart attack rate. I think this is worth paying attention to, as I'll show you. The successful trials, instead of targeting depression, target anger, generally speaking. There is this sub-study that I showed you from the Montreal Heart Attack trial of anxiety. There is one study for depression in elderly folks. And then there are a couple of small global studies of emotional distress that had a dramatic effect. But they looked at what's called MACE, or major adverse cardiac events, and included revascularization. Revascularization is heavily determined by whether or not you're symptomatic. So whether or not you're going to get bypass surgery or angioplasty is almost totally determined by whether or not you're symptomatic, which is a marker, frankly, of depression or anxiety. So there is just recently, just in the last 18 months or so, one large placebo-controlled trial of an SSRI. This is escitalopram. Commercially, it's known as Lexapro. You don't have to buy Lexapro. You can buy the global drug. Lexapro is the L-isomer of citalopram. Citalopram's much cheaper. But the reduction in risk is about 30%, which is, again, is in the same range as we see with the other drugs. The weakness of this study, I think, is that they pre-selected for depression. If they had included anger patients, I suspect this would have been much stronger. Because frankly, that's what I have ended up doing for the last 20 years as a result of discussions with a colleague from Massachusetts General. I spent about 5 years trying to convince the drug companies to fund me to do this study 20 years ago, and I couldn't get them to sign on. These drugs also seem to affect stroke rates. Interestingly, this was done by one of my mentors from my internship year. But stroke rates actually went down over 2 to 9 years in patients who received antidepressants. They were only given the antidepressants for 12 weeks. After that, it was up to them whether they wanted to continue them or not. It was left up to them. But there seemed to be this long-term effect on their stroke rate. This is studies of reductions in measures of depression as a result of citalopram in the light blue, and then the placebo group is in the dark blue. Notice, this is true of all drug trials for things like depression and anxiety. Notice that there's a large placebo effect. Even though citalopram does somewhat better than placebo, it doesn't look dramatic. It looks even better, frankly, when you measure hostility or anger. The placebo effect is there still, but it's not as potent as treating the anger with drugs. Now, in addition to affecting heart attack rates, it's the case that treating emotional distress in cardiac patients reduces symptoms. And because it reduces symptoms, it reduces the propensity of patients to seek out treatment, and it reduces the anxiety of doctors that produces the amount of treatment they get. This is a study of ours that looks at anxiety, particularly anxiety and phobic anxiety, as predictors of costs over the course of a year. And if a patient is anxious, they cost about 50% more to take care of than a patient who's not anxious. This is a study at the clinic that looks at psychological distress as a predictor of post-hospitalization costs for the first 6 months after being discharged from the Mayo Clinic. And you can see that the non-distressed patients are much less expensive to take care of than the distressed patients. They're far more likely to be rehospitalized. This is basically the same data depicted somewhat differently. Psychological distress costs about $8,000 over the first 6 months, whereas having diabetes costs about $5,000. Having a low ejection fraction costs about $4,000. This is a study we did of acute MI patients. We contacted them within 24 hours of admission to our hospital and tried to talk to them about stress and heart disease, and offered to refer them for follow-up therapy. None of them took us up on it. However, they all received the chapter I sent you on type A behavior. And you can see that we reduced length of stay somewhat modestly, but we reduced the 1 month readmission rate by about 80%. Simply giving them a book chapter to read about type A behavior had a dramatic effect on their rehospitalization rate. Jim Blumenthal at Duke University looked at 1-year costs and 5-year costs for, these are patients who had known coronary disease. So they'd had a positive cath finding. And they received usual care plus stress management, usual care plus exercise. And you can see that both at 1 year and at 5 years, they were less expensive to take care of. Again, fewer symptoms, fewer treatment seekings, and fewer doctors who are anxious and running all sorts of tests. Gunilla Barill's study in Sweden looked not just at the reduction in total mortality, but also at the number of days patients spent in the CICU after the study, and found that she reduced the rate of CICU days, which are about $5,000 a day in the States, by about 60%. One of the interesting things about symptoms in cardiac patients is that they're not very strongly related to what doctors think they're related to. It's actually not usually due to ischemia. So if we look at angina in patients with known coronary disease, those who are having chest pain, a Holter, I should explain, a Holter exam is when they put an EKG on you and you walk around for 48 hours or 72 hours doing your usual activities. And when you have chest pain, you're supposed to punch a button on the Holter belt. And it turns out that most episodes of chest pain are not accompanied by EKG evidence of ischemia. And but the reverse is also true. When you have ischemia, you will almost always not have pain, about 70 to 80% of the time. So most ischemic episodes are what we call clinically silent, meaning they don't have symptoms. And in fact, about 25% of heart attacks are termed clinically silent, meaning that they're not diagnosed at the time they occur. They're detected later And we're not clear about whether they were truly asymptomatic or they were symptomatic, but the symptoms were not severe enough for the patient to take himself to the emergency room. Angina is strongly affected by placebo effects. The first placebo-controlled trial in the States, actually in the world, as far as we know, was done by a guy named Gold, who looked at placebo versus xanthine. Xanthine was apparently a treatment for heart disease back in the 1930s for reasons I don't understand. But it turned out that there was no effect on chest pain. Internal mammary artery ligation, back in the days before we had IRBs to deal with, they actually did 2 sham-controlled surgical trials, no effect on chest pain. And then for angioplasty, there have been 13 randomly assigned controlled clinical trials. The most recent major one was the COURAGE trial, which before the COURAGE trial, we used to believe that there was a 60 to 75% reduction in chest pain. But actually, when we compared angioplasty with usual care, just medication care, there was only an 8% reduction at 1 year, 5% at 3 years, and no significant difference in 5 years of follow-up. More recently, there's been actually a sham-controlled PTCA trial that found no effect on chest pain rates. One of the things that does provoke ischemia is panic attacks. So patients who are having a panic attack are modestly more likely to develop ischemia than patients who don't without a panic attack. Now, we took part in a multi-center study some years back where we looked at laboratory provocation of ischemia in patients with known coronary disease. And we stressed them in the lab in several different ways. We had them exercise on a bike. We had them give a 5-minute speech. And we had them do the Stroop task, which is a color word task. It's not important that you understand that. But exercise provoked ischemia much more reliably. Speech was not as reliable, but the problem is that how often are you stressed by exercise, and how often are you stressed by interacting with other human beings? And the answer is you're far, far, far more likely to go through conflict with other human beings than you are to exercise during the day. The way these speech tasks are done is you give them a task to do. So you will say to them something like, let's pretend that your mother's in a nursing home. I'm the manager of the nursing home. You don't think she's getting her medications on time. They're not getting her the bedpan on time. And your job is to convince me that my people aren't doing their job. As long as the patient's talking to me, I just sit there and scowl at the patient. But if she stops talking, I start saying things like, well, my people are very busy. Your mother's very demented. She wouldn't know whether she was having problems or not. So you basically, it's the task of the examiner to try and provoke anger or resentment on the part of the patient. For a small number of patients, we get them to cry, but most of them get angry at us. We looked at measures of psychological distress and different symptoms of heart disease. And what we found was that the strongest predictors of symptoms of palpitations and fatigue is whether or not you're somatic, meaning you have lots of physical symptoms. The best predictor of dizziness was whether or not you're obsessive compulsive. And the best predictor of angina and dyspnea, shortness of breath, was our measure of anxiety. One of the questions we have is how can we help identify these patients? And these are fairly standard measures of stress in heart patients. The only one that showed a trend in the right direction was the patient. This is a measure of depression, standard measure of depression, with a p-value of 0.058. Our spousal measure was far, far better, far superior, particularly for anger. looking at predictors of early onset heart disease. Jeff Huffman at Mass General looked at complications for patients during their hospital stay and found that if patients who had high anxiety had far more chest pain, far more ventricular arrhythmias, far more episodes of chest pain, or pardon me, of heart failure, and overall had a worse course in the hospital than people who didn't. Stress management affects chest pain. Gallagher did a study of outpatients and put them through stress management and looked at both exertional chest pain and resting chest pain. Found a dramatic drop in resting chest pain. Resting chest pain is considered more malignant than exertional chest pain. It's thought to be unstable. It implies that whatever it is that's causing your chest pain and presumably ischemia, although probably not ischemia, is unknown. Ornish's program, you may have heard of Dean Ornish. He has this lifestyle program for heart patients. Demonstrated a dramatic drop off in chest pain and an increase in his control group. So if they don't receive stress management, they actually do worse over time. One of the questions I'm often asked is, when should we screen? How do we know who should screen? And I don't have a hard and fast answer, but these are the kinds of things I've thought of over the years. Any hospitalized patients with acute coronary syndrome, anybody who's diagnosed with heart disease, anytime they're concerned about noncompliance, and anytime the patient has persistent chest pain, fatigue, or sleep complaints. There are a number of medical conditions that can mimic various manifestations of stress, including steroids, beta blockers, digoxin, or statins. Substance abuse obviously can do this. A number of medical conditions can mimic emotional distress and need to be sort of taken out of consideration. Let's see, we've already looked at this. One of the complications of using antidepressants in patients, well, in any patients, is that people gain weight. And when you gain weight, your risk of diabetes starts to rise. However, if you use low dose antidepressants, there doesn't seem to be a detectable rise in diabetes. So over 12 to 24 months, people who are on low doses, the confidence interval stays around 1. Excuse me. SSRIs have all sorts of side effects that have to be considered in choosing the drugs and whether or not the patient can tolerate the drugs. I don't think we need to go through these. I've done a number of review articles, but unless you're interested particularly, I'm not going to belabor these. If you're interested in this topic, the best thing I can recommend to you is to get Friedman's book, from the book chapter I sent you. It's called Treating Type A Behavior in Your Heart. You can get used copies from Amazon. It comes in both paperback and hard form. There are people out there now trying to charge like $300 a book, but if you click on the site, you can get it for like 10, 12 bucks in both hardback and paperback form. There's also another book you might find interesting called Eisenhower's Heart Attack. It goes through Eisenhower's experience with heart disease and illustrates type A behavior. He was apparently a pretty intense type A, had a terrible temper. And the treatment for his stress when he had his heart attack in 1956 was to have him basically resign from the presidency and let his aides run the country, which is basically what he did. He would sort of get together with them at the end of the day. They would tell him what they'd done. He would bless it, and that was the way the country ran itself. Thank you for your time and attention. Any questions I can try and answer?
wonderful talk. I have an observation and then a question about the placebo trials. So the observation is someone who's published a fair bit in some of the biomedical area. I always prefer absolute risk reduction as a thing to include also. After all, if the chance of myself is in my mid-70s, if you reduce the risk of something from 1/100% per year to 1,000% per year, that's a humongous risk reduction, but probably ignorable. And so I always don't like just stating relative risk reductions. They at times, it could be very important, it could not be. But the other question that I've had in some of these, particularly what you're doing in observing the placebo effect, is sort of the following. I observe a change with the placebo, what I'd like to be able to somehow measure, but I know I can't. And is there a way around this? Is, a similar progression with sort of no interaction at all with the patient. In other words, you're counseling for X or Y or not. So the person's in these sham sessions, or there's, drug A versus sugar pill, or, a COVID shot versus a shot of saline. How do you manage to sort of compare the, maybe it's important that the placebo causes a reduction, which no treatment wouldn't. How do we handle that?
Well, there are a couple of answers to that question. The first is, does the placebo reduce your risk for a heart attack or death as much? So if you can reduce the risk of a heart attack by, say, 5%, which is about what we're talking about with the escitalopram trial, that's considered a successful treatment. And it's part of a regimen in addition to the other things you're taking, the beta blocker, et cetera, that reduces your overall risk. My answer for people who say, I don't like taking pills, or I don't like taking pills that I think affect my head, that sort of thing, is, hey, try it, give it a month or two and see how you feel. Because most of my patients or their spouses will say to me, I feel better, I sleep better, I have more energy, I get along better with people, that sort of thing. I have a large number of patients whose spouses, once they're on the pill, will call me and say, don't take him off that pill. He's much easier to live with. I've had several patients who tell me, I had one guy who ran an auto plant, who was what we call alexithymic. He was not good at observing his own emotional states. He said, I don't feel any different on this pill, but I think it's working. And I said, well, how do you know it's working? He said, people don't hide from me anymore when I walk through the plant, which he took as progress. So there are multiple possible reasons.
Look, I'm in favor of all these. I've been taking a number of things for many years, and in fact, I'm only here these days because of some of them. But I mean, by medicines, I don't mean, illegal drugs and whatever. But I mean a variety of medications, prescribed medications. But when I teach astronomy, I like to tell my students, astrology works. If I told you that, the moon is in the second house and tomorrow's a great day to bump off the king, and the people are psyched up because of this. And in fact, they're more likely to win. And this has been found in teaching. You tell a teacher that you've got a class of very good students, they will do better on standardized tests. And
Right, right.
this is the part that, I mean, I think that a number of fields, including counseling, are well underestimated, their value in things. And when I mention this question, I think they're very much underestimated in terms of their benefits. But it just seemed to me that some of these things are just very, very hard to figure out. And I guess I applaud you for you get a wealth of data in different ways, and it tends to be quite convincing.
I think if you're going to understand something in medicine or something in behavior for that matter, you have to be able to think in terms of populations. I don't know if you've ever read the book called The Signal and the Noise by Nate Silver.
Yes.
It's an excellent discussion. You have to be able to think like a statistician in order to think clearly, I think, about what we do and whether it's effective and whether the size of the effect is large enough to make it worthwhile and that sort of thing.
I consult in biostats, had been doing that at Long Island Jewish for a number of years, Long Island Jewish Hospital, and I'm working with a number of groups now as someone who's retired. Well, let me just conclude with I want to leave this on to others, but when I teach intro data analysis, just for fun to people, I have them graph the men's mile time as a function of the year.
Right.
And what you observe is it declines at a straight line at roughly half a second per year until it reached 4:01, and it sat there for a few years.
Yeah.
Once Bannister went through 4 minutes, it just resumed the old line.
Right.
It's just interesting. There was a barrier that had nothing to do with, well,
it was a psychological barrier.
And whether that affected your physical limits or not, I don't know enough to say. But there's no reason why this magic number of 400 should be any different than 358.2 something.
Right.
Yeah, Harold, there's one thing I think Mark would agree with me on is that, especially when it comes to psychological, what would you say, interventions, that the placebo is amazing. And people who are depressed or anxious probably just enjoy having some people to talk to that are neutral listeners. And to go and add a drug on top of that sometimes just has no effect. And this is why you need the placebo. And it's taught to us that the placebo is everything but the drug, including the pill as a sugar pill and the intervention. And when it comes to depression, consultation and advising are often enough to cure depression. And then sometimes you add a drug on top of that, you see no effect. So today's studies uniformly include an active arm where you put Prozac in the studies, and sometimes you see no effect and you call it a failed trial. And you can't tell if your experimental drug worked because the Prozac didn't work. And people say, well, Prozac doesn't work anymore. It never did. Well, in fact, the counseling is there and the placebo is there, and the Prozac, sometimes you just don't even need it. But just having people being attended to that are anxious or depressed probably helps. And that's where that strong placebo effect is. But, today's medicine doesn't allow an awful lot of counseling sessions, and drugs are cheaper. That's where we're at. So.
No,
I think medicine has gotten away with a lot of things because there's a placebo effect going on that neither the doctor nor the patient are thinking about. They're assuming that it's the pill that's curing them.
Right.
There are studies of different physicians which find that some physicians are naturally more effective than other physicians. And when you look at what they do that's different, they seem to be much better at connecting with patients, at listening to patients, at explaining things to patients at a level that they can understand, and not being in a rush. So there's some kind of social feedback that seems to work better for patients. And it seems to be a characteristic of the personality of the doctor.
Well, I think you find, interestingly, in my main profession, which has been college teaching, that you have personality effects and people's reactions to teachers. And I've often said, if you think you've got a better syllabus, what I'm really interested in is not what you do with it. Maybe you're so good you would do well with something that's pure BS. You want to give it to someone else and see do they do better.
Right.
You take yourself out of it, and it's just fascinating to me. And you know, I even think in many ways the fact that different people have different reactions to things is that we're really sort of reacting to an internal model that we've created.
Mark, can you close your PowerPoint, then we can see who's still here.
Does that work?
Yeah. Any questions from others?
Yeah, I had a question. So there's stress in life, of course. You know, I think of mountaineering or travel, going through borders is stressful. You know, I hope the lesson here is I shouldn't remove all stress, right? Is it just high levels of stress that's dangerous, or what are your thoughts on that?
Well, I think the reality of human life is that we evolved to escape saber-toothed tigers, and you know, you can't entirely escape stress, and frankly, it's probably not even good to entirely escape.
Yeah, that's what I was wondering. If actually benefits the stress.
At some level, you know, boredom is a stressor in its own right and in unique ways. But what we worry about is not someone who's feeling down or depressed for a few days or even a few weeks. But when it gets to be a few months, we worry a lot. These symptoms have a strong genetic component. So if you look at depression, the heritability of depression is about 50%. The heritability of anger is about 50%. So if you have a cranky daddy, the likelihood that you're going to be a cranky personality is substantially higher than if you don't. And the same is true for anxiety disorders. It's the chronicity of stress that we worry about. Most sophisticated doctors will not worry about the patient who's going through a current crisis unless the patient's talking about suicide, or the patient's starting to drink a lot, or the patient's engaged in some kind of unhealthy behavior.
Thanks.
Mark, even though cortisol antagonists don't seem to work in depression, have they done anything with coronary artery disease and cortisol antagonism?
Not that I know of. Maybe it's out there, but I'm not aware of it.
Okay. Well, I think that when we get our vaccines, our stress level will come down. And in a couple weeks, no, on the 29th, we're going to have Rick Schumann come back to talk to us about vaccines. And he's going to be talking about the 4 major vaccines that we are familiar with, that we've been reading about in the news. I think Novavax will be the next one, and there's an Oxford after that. And then the 2 main ones that we've been looking at, like Moderna and BioNTech. So that should be interesting. Next week, we're going to have Daniel Rosinol talking to us about what you have to go through to get a drug to market, all the hoops from the FDA and whatnot. And let's see, I think, and John Miller is going to be returning to do a talk on infrared, the history of infrared, and he knows that subject very well. And so I think we can call this off. I think we've reduced your stress by not having you watch the television for the last hour and 15 minutes.
Yeah.
Happy New Year,
Actually,
everybody.
we have closed caption running as we're listening to you. So in a sense, our stress has not been reduced.
No, sorry to hear that. Yeah.
It went down about 5 a.m. this morning when I kind of really realized we'd won both of them in
Right.
Georgia.
Yes.
And,
Yeah.
Much relief that was.
Amen
right?
to that.
If it weren't for that, the whole day would have been really awful,
Yeah,
wouldn't it?
yeah, yeah.
The whole day's awful anyway.
It's a miracle.
If you
I
want,
have one
Bruce, I'll
quick question, if I could. I know you're talking more about the psychological effects. My family has a deep history of cardiac disease. My mother, my sister, my brother, and myself. It's one vessel disease. I have had an MI. I was only 57 when it happened. And it's the right coronary artery. And we have many stents. And I keep saying to the different cardiologists, surely somebody wants to do a study about us, you know? My sister, my mother ended up having bypass surgery. Fortunately, I haven't had it as bad, but I have about 6 or 7 stents. I can't even keep track anymore. And it's one vessel disease. And it is not, you know, it's just weird. And we don't know why.
Is it always the same vessel, Judy?
Yeah, right. It's the RCA.
It's always the RCA. That is interesting.
It is.
You sound like a great case vignette to be written up by a resident
Well,
or a
I've
fellow.
offered myself. I'm a cardiac nurse. On top of it, I diagnosed what was happening to me when I had the MI. I had an inferior wall MI. I could tell by looking at the EKG when the EMTs arrived. I knew what was going on, which is pretty weird, let me tell you. But it's just, there's such a genetic factor in our family. And it's tied in with some other things. It's not just cardiac, that we all have. I just think we'd make a great research project for someone, but unfortunately, my mother and sister have both died. So it kind of eliminates some of the, but yeah, you know, it's been an issue, and I've learned to just not worry about it. I can't. You just go on. What I can do. All right. But thank you.
You stay alive, Judy. We have more talks for you to do.
Oh,
please.
I'm pretty good about, I know when it's happening. I just hop in, my husband takes me right down to the, you know, the St. Francis Hospital, a cardiac hospital, and they put another stent in me. And I've been very lucky since that one incident where I ended up in the ICU. But that was at Mass General, so I had wonderful care. We were living in Boston at the time. But it's just weird because in addition to this, my mother and my sister also had pulmonary fibrosis, which I never thought was genetic, but apparently it can be. And we all had various GI problems that are identical. So it's just been very weird. And I'm worried about my kids. My kids, you know, I'm always giving them a hard time because of that. It's in the family. But that's just, what are you going to do?
We're not going to get out of this thing one piece.
That's right. That's right. Okay. I'm going to go back and watch this. It's only going to go on for about another 6 hours, I think.
Yeah. Get some sleep
Well,
tonight.
let me thank you for the Wood Wide Web talk. That was just amazing. And then, you
Thank
know,
you. I gave it again, actually. I gave it again yesterday. I gave it yesterday again to a very different group, all professionals. So, and it was fun and it was well received. And I love that I'm getting little notes now from people all the time. It's a good topic.
You should give a talk on what is consciousness.
Oh, actually, I'm not into that as much. I'm more, you know, I'm a nurse and a scientist, and I'm much more into physical things and not the things that you have to think deeply about. So we'll see. I'm doing a talk on, I've done several talks on Marc Chagall, but that doesn't apply here. I'm very fascinated with a lot of different things. I've done talks on Homer, both of his books I talked about.
We have to
But-
keep this going through the pandemic, so,
Oh, I'm in for the long haul.
okay. All right, I've got to go. I don't know about the rest of you guys. It's been a long,
Okay. Yeah, we're
Long
going to
day.
have to go.
Thank you.
thank you,
Good night,
Mark.
everybody.
Beautiful job.
Thank
night.
you.
Read the articles, everybody.
Okay.
Thanks, Mark.
Happy New
Bye.
Year.
Happy New Year.
Happy